Welcome to the conference session titled Treating PNH. Thank you for joining us. My name is Alice Hauk, Senior Director of Patient and Professional Services at AAMD-SIF, and I will be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help us manage the incoming questions. First, submit your entire question all at the same time. And second, please do not share private health information in your question. Our speakers cannot answer any specific questions related to your health care. Today's specialist is Dr. Anand Karnad. Dr. Karnad is Chief Division of Hematology Oncology at the Department of Medicine at UT Health San Antonio MD Anderson Cancer Center and has been Professor of Medicine there since 2004. He has been an active investigator for the National Cancer Institute clinical trials for 2 decades, including trials designed to prevent and treat a range of cancers. His clinical research interests include sarcoma, hematological disorders, and geriatric hematology oncology. His career goal is to improve the care of patients with blood disorders and cancer through accelerating the completion of clinical trials and in helping to train the next generation of hematologists and oncologists. With that said, welcome, Dr. Karnad.
Good morning, and thank you very much for giving me this opportunity. I will share my screen with the slide set and take you through this talk on a condition that's quite rare, paroxysmal nocturnal hemoglobinuria, or acronymed PNH. Before I get into the talk, just a quick overview of the entire presentation. I will start by giving you a history of what we know about this condition, a timeline, if you will, just to set perspectives on what this condition is like, how was it first described, and what do we know about it today. I will pay respect to the pioneers who have helped us understand this condition. We will then get into a description of the natural history of this condition when it does arise. What does it do to people? How do we make a diagnosis? And what are current treatment approaches for this condition? So before we get right into the talk, a little bit of a perspective, since this extremely rare disorder affects many things, but primarily at the heart of it all is the red blood cell. And the destruction of red blood cells in this condition gives rise to severe anemia and its complication. And we must acknowledge that the red blood cell is quite an extraordinary structure in our bodies. We have about 5 million red blood cells in a drop, a cubic millimeter of blood. We have 5 liters of blood in our system, and there are that many red blood cells. The red blood cell is quite unique as a cell within our bodies. It does not have a nucleus within it. As we understand biology, the nucleus of a cell is like the master regulator of all its functions. However, the red blood cell does not have a nucleus. The nucleus gets ejected out when the red blood cell is produced and reaches maturity. And the red blood cell is nothing but a bag of membrane which encloses a very important protein called hemoglobin, whose only job is to pick up oxygen when we take in a breath and then the red blood cell travels through the body, delivering this oxygen to the tissues. In its long sojourn from its birth in the bone marrow through the circulation, the red blood cell has to squeeze through really tiny openings. And this membrane, the red blood cell membrane, is so extraordinary. We have learned so much about its structure that hematologists like me are fascinated when we partner with people beyond hematology, like structural engineers, who have told me that the red blood cell membrane is so flexible, yet so strong. Flexible because it has to squeeze through the tiniest of openings in our blood circulation. Strong because it has to bounce around the circulation, ejected out from the heart. It has to really experience such severe shear stress that engineers say that the red cell membrane is as soft, softer than latex, but stronger than steel. If you think about what happens to a normal red blood cell, the normal red blood cell, when it reaches about 3 months of age, is cleared out of our system by our spleen, which is an organ that sits just under the left side of our rib cage. And the spleen is like a garbage disposal unit, if you will, clears out many things, and it certainly clears out old red blood cells that have reached the end of their lifespan of about 3 months. Now, this destruction takes place within another cell called the macrophage, which is the garbage disposal unit, and nothing happens within the circulation. In other words, the destruction and elimination of normal red blood cells takes place within other red blood cells in the spleen and not within our blood circulation, not within the blood vessels. And therefore, when a red blood cell breaks apart or is destroyed within the blood vessels, that is distinctly abnormal. And it releases the protein within the red blood cell called hemoglobin. And this is so dramatically abnormal that there are a whole host of conditions besides paroxysmal nocturnal hemoglobinuria that have red blood cell destruction within the circulation, all of which are usually fairly severe, thankfully uncommon, and produce the kind of manifestations that one would describe in patients with paroxysmal nocturnal hemoglobinuria. Okay, so with that background, then let's go in to look at the historical timeline of this disease. So in 1882, Paul Strubing in Germany described a 29-year-old man that he had seen with severe fatigue as the predominant symptom and anemia. And it was so many years later that there was a test identified by Thomas Hale Ham at Boston City Hospital that eventually helped us understand what this disease is about. In 1882, Paul Strubing described this condition, and he did a pretty good job at outlining what happens. He said that this patient had severe anemia, explaining the fatigue. And he said, peculiarly, the plasma in this patient was pinkish red. And so he said, you know, the red blood cells appear to be destroyed within the circulation. And there is something in the urine that comes out. And maybe it is this byproduct of destruction of the red cell within the blood circulation that is causing all of this patient's other manifestations, which were severe abdominal pain and cough. So early on, there was this clear description that this destruction of red blood cells, in medicalese called hemolysis, occurs within the circulation and not in the spleen. Thomas Ham then said, I wonder why Paul Strubing said that he experienced this patient's symptoms to occur mainly in the evenings or at nighttime, and that the urine in the morning was dark in color. And this destruction appeared to be more during sleep. Paul Stubing himself had postulated that maybe when we sleep, we breathe a little slower and there is more accumulation of carbon dioxide, and that has something to do with acidifying the environment that destroys the red blood cells. So Thomas Ham took red blood cells from people with suspected paroxysmal nocturnal hemoglobinuria and showed that they fall apart when the serum is acidified, but not when the serum is normal or alkaline. He also showed that red blood cells that are normal, his own red blood cells, for example, do not fall apart when they are in an acidic environment. And so for 100 years or so after the first description of paroxysmal nocturnal hemoglobinuria, the main test from 1930 onwards for about 50 odd years was the only test available to make a diagnosis of paroxysmal nocturnal hemoglobinuria, called the Ham test. So from 1989 onwards, it became known that the problem with paroxysmal nocturnal hemoglobinuria has to do with a problem with an anchoring protein within the red blood cell membrane. This anchoring protein anchors two specific structures, one called CD55 and another called CD59, that appear to protect the red blood cell as it flows through our circulation from being inappropriately destroyed within the circulation by parts of our immune system called complement. So it protects the red blood cell from complement-mediated destruction. In 1995, there was a paper in the New England Journal of Medicine that described the natural history of this condition, and we will look at features of what they said in 1995 about this problem, when the only treatment for paroxysmal nocturnal hemoglobinuria at the time of this New England Journal of Medicine paper in 1995 was just supportive care. You could transfuse people with PNH with red blood cells, give them pain medicines, and hold hands. It was in 2006 when eculizumab, which is a medicine that blocks complement, was shown to be effective for paroxysmal nocturnal hemoglobinuria. And therefore, on the right side of the screen, this arrow, solid arrow that says a life-changing treatment was introduced. The era before eculizumab is an era of supportive care and quite miserable quality of life for people with paroxysmal nocturnal hemoglobinuria, and for life after 2007, quite different. And we will spend the latter half of this talk looking at what has happened in this modern era of understanding and treatment of PNH. Paying homage to pioneers, on the left of the screen is Sir John Dacey, the late Sir John Dacey from the United Kingdom, who spent his career at Hammersmith Hospital in London, who did a lot to outline a variety of hemolytic anemias due to red blood cell destruction. And in the middle are a band of warriors, if you will, in the 1930s, whose sleeves rolled up, as you can see, in a hospital that served the inner city poor of Boston at Boston City Hospital, made many, many contributions to hematology. Specifically, this individual with the apron, who is Thomas Hale Ham, who was credited with perhaps introducing the first diagnostic test for PNH, and did a lot to help open the doors to understanding of this disease. His senior colleague to his right, Dr. William Castle, did many things for hematology, including describe why pernicious anemia occurs. And Lucio Lozato, who has done an incredible amount in conjunction with John Dacey's group, who has pioneered the understanding of the genetic basis of this disease, and including developing many of the treatments that we will soon see. Thomas Ham in 1930, when he identified this acidified serum test to make a diagnosis of PNH, made a prescient observation. He said that PNH, he described it as a knothole disease, and that if you peered through the fence of PNH, you could actually see the whole ballpark of biology and hematology in front of you. And he said this at a time when there was very little understanding beyond red cell destruction, what exactly caused this disease, and there was no treatment available. And we'll see a little later on how predictive this description was of Thomas Hale Ham, that PNH is a knothole disease that will introduce so many different aspects of biology and hematology. So at the heart of PNH is the red blood cell that is being destroyed. So what is in this name, paroxysmal nocturnal hemoglobinuria? Paroxysmal in that it occurs in spurts, in starts and stops, abrupt, but this is not the case in all people. In some patients, this is a very gradual condition that causes anemia. Nocturnal, occurring at night. Again, the descriptions are historical, and that this does not always mean that it is specifically active at nighttime. We have understood why during sleep the serum may indeed become a little acidic and contribute to greater destruction of the red blood cell. And that the red blood cell, remember I told you at the start of the talk that normal destruction of aging red cells occurs outside the circulation, within cells in the spleen. The falling apart or destruction of red blood cells within the circulation releases hemoglobin that is then ejected into the urine, that results in dark colored urine or hemoglobinuria. So paroxysmal nocturnal hemoglobinuria is a historical term for the manifestations, if you will, of this disease. How rare is it? If I start on July 1 of 1985, when I first entered the grounds of Boston City Hospital to start my training as a hematologist, as a hematology fellow, continuously from 1985 until today, I think I have looked for PNH in hundreds of patients, but I have personally made a diagnosis of PNH in very few, and I've cared for only a half a dozen patients with PNH. PNH is a rare disorder, 1 patient per million people worldwide, and affects an age range of people between the age of 30 to 59 and is extremely rare in kids. What does it do to a person? You know, just a day or two ago, I was taking care of one of my patients with PNH who was routinely in for treatment. And I spoke with her. I give her a pseudonym, Ms. Albright. And I asked her, I said, can you recall what it was like when you first were diagnosed with PNH? And she said, oh my God, I felt miserable. And I think I remember clearly she used the words, I was bone tired. So anemic that at one time my hemoglobin was down to 4, needed transfusions all the time until they figured out what was wrong. And then there was that awful blood clot in my left leg. So she described the key features of paroxysmal nocturnal hemoglobinuria: severe fatigue associated with anemia that often requires transfusions, and a very high risk for thrombosis or blood clots. So based on my patient's terms and descriptions, let us look at what Sir John Dacey and Dr. Luzzatto said in 1995 in that paper I was talking about in the New England Journal of Medicine, where at the Hammersmith Hospital in London, they had a registry of 80 patients, perhaps the most comprehensive early patient registry of PNH. And they made the following observations. And I must point out that they had so compulsively followed patients. They had a record of a patient who had been followed continuously for 48 years, described in this paper. So the natural history was really very well outlined in this paper. And I give you the highlights. In patients were about 40 overall, and between the ages of 16 and 75. Hemoglobinuria, or the finding of red cell destruction within the circulation so that you could find hemoglobin in the urine, was seen in 80% of their patients, 60% of whom had some form of thrombosis within their lifespan or hemorrhage. They described spontaneous remissions occurring in 15% of these people. Throughout the natural history of their patient population, transformation to malignancy or leukemia was not known to have occurred at all. And the median survival of their cohort of patients was 10 years at that time. In that era, the only effective approach to PNH was just support, transfusions, and management of thrombosis. A select few patients then had gone on to stem cell transplantation as a potential cure for this condition. So knowing the natural history of this, then let us understand the effects of PNH. Destruction of red blood cells leading to anemia, blood clots that happen within the circulation, and the thrombosis is predominantly venous, and it affects peculiar sites. The dominant sites of thrombosis are within the abdomen. It's not a very common site for people to have blood clots. I see patients with nothing but thrombosis all day long, every third Thursday of the month. And I must say, it's the minority of those patients who have blood clots in the veins that take blood out of the liver, hepatic veins, veins that take blood from the bowel through the liver, such as the splenic vein, the superior mesenteric vein, the portal vein, and so on. Very, very uncommon for thrombosis to occur, but this is the dominant spot for thrombosis in PNH. Muscle spasms causing pain. I remember a 20-year-old lady I saw when I was in Tennessee soon after my training, who'd had multiple abdominal surgical procedures looking for the cause of severe abdominal pain, but her spasms causing that pain were not from bowel obstruction, but from this unique problem of smooth muscle spasm that occurs when hemoglobin is rapidly released in the circulation that consumes nitrous oxide, and that causes smooth muscle or blood vessel spasm, causing severe pain. Patients can have trouble swallowing, etc. Fatigue out of proportion to the degree of anemia, episodic jaundice or yellow discoloration to the skin and the eyes, dark colored urine, and rarely injury to the kidney and the lung. When should we, or when do we think of paroxysmal nocturnal hemoglobinuria? Every time I see a patient with anemia, especially when the anemia is caused by red cell destruction, especially if the common conditions are ruled out, we look for PNH. We look for PNH in people who present with unusual sites of thrombosis, people who have liver vein thrombosis, or people who present with cerebral vein thrombosis for no apparent reason. And of course, in people who have bone marrow failure, aplastic anemia, or low blood counts, and we'll see why there is this relationship between PNH and aplastic anemia. So how is this diagnosis made these days? We no longer rely on the HAM test. It's a test now relegated to history, but now we have a specific test called flow cytometry that identifies the absence of these protein structures on the red blood cell that are anchored to, should be anchored to the red blood cell membrane. And because the defect in PNH, as you'll soon see, is this anchor is missing. The proteins are no longer present on the red cell membrane, and so the red cell is not protected from complement-mediated lysis. So we can look for these proteins on the red blood cell by a technique called flow cytometry that is highly sensitive to pick up this diagnosis. So if we look at the normal red blood cell, then it has two proteins. We can identify them as CD55 or CD59. They're held in place on the normal red blood cell by an anchor protein called PIG, or phosphatidyl inositol-glycan. It anchors these two proteins to the red cell, and this anchor function is so important, and these two proteins prevent complement from being activated and protects the red cell from hemolysis. The PNH red blood cell, because it lacks this anchor protein, does not have the CD55 and CD59 proteins, so complement gets rapidly activated, and the end result is that complement then is activated to produce this membrane attack complex, such a horrific protein that pokes holes within the red blood cell. Water rushes in, and the red cell falls apart within the circulation, resulting in all of the problems. So if we have to understand what actually causes the lack of this anchor protein, it took a lot of work to identify that this is a somatic mutation within a gene called PIG, phosphatidyl inositol glycan group A. This mutation within the stem cells, within the mother cells of the bone marrow, results in absence of this anchor protein, so that CD55 and CD59 are no longer expressed even within the stem cell. So this event alone is not sufficient, apparently, for PNH to occur. There needs to be an antibody that attacks the rest of the stem cells that have this anchor protein and eliminates them, so that the clone that has the PIG mutation alone gets selectively advantaged from a combination of this genetic mutation that eliminates the anchor and an autoantibody that destroys red cells that have the anchor, resulting in a dominant clone of stem cells that have this PNH mutation, resulting in all of the manifestations. And so if the autoimmune destruction of stem cells that have normal anchor proteins dominates, then the person develops aplastic pancytopenia. If the clone that has the PIG-A mutation dominates, there is selective advantage of this clone from autoimmune destruction of normal stem cells, resulting in PNH. So there is a link there. There are rare genetic conditions that affect other PIG genes, one called PIGT deficiency. It's a biallelic mutation that produces similar problems to PNH, but extremely rare. And then PIGM mutations that result in blood clots and seizure disorders, but no manifestations of hemolysis. All this has taken extraordinary work and collaboration to understand. So how does treatment work in paroxysmal nocturnal hemoglobinuria? Well, if you can block complement activation, remember that PNH red blood cells lack CD55 and CD59 that normally protect the red cell from complement-mediated lysis. And since they do not have this anchor protein and CD55 and CD59 are absent, complement, which is part of our immune system, dominates and produces this terminal membrane attack complex that results in red cell destruction. Eculizumab is an antibody that affects this terminal activation of complement. And if you block this, red cells, PNH red cells survive. And so there is less anemia, less problems due to red blood cell destruction, and people feel better. So this happened in 2006 when Peter Hillman Neil Young, Dr. Brodsky, Dr. Luzzatto, they published in the New England Journal of Medicine the first use of eculizumab as an inhibitor or an antibody directed against the terminal phase of complement. In the top phase, the top bar represents LDH, which is an enzyme that is released in high levels when red cells fall apart. So the minute you start a patient on eculizumab, you'll see that their LDH levels plummet and stay low on eculizumab, whereas those who are getting the placebo continue to destroy red cells and have high numbers of LDH enzyme in their blood as a marker of ongoing hemolysis, whereas there is no more severe hemolysis occurring on eculizumab. If you look at the dependence on transfusion, people who are receiving placebo continue to be transfusion dependent, whereas people on eculizumab had less transfusion need, albeit not completely eliminated. And finally, if you looked at how fatigued or tired people with PNH were, there was worsening fatigue, obviously, with people getting placebo infusions, PNH patients getting placebo, whereas those who are getting eculizumab had dramatic improvement in their fatigue scores as their hemolysis improved. And so starting in 2007, when the approval of eculizumab, it transformed the lives of people with PNH, and people with PNH were free from needing red cell transfusions. The risk of thrombosis plummeted, decreasing by over 85%. And there was an improved sense of well-being and quality of life in most people with paroxysmal nocturnal hemoglobinuria. Still, challenges remained. Some people with PNH on eculizumab had less than an ideal response to standard therapy for a variety of reasons that are now increasingly understood. There appeared to be breakthrough destruction of red cells on eculizumab. Some people developed, frankly, a refractory state. And then patients needed maintenance treatment with injections every 2 weeks, which interfered with work, which interfered with social activity. And of course, that resulted in some decrease in compliance. And then there's the tremendous cost of treatment continuously for those who need maintenance. To overcome these challenges, then, there were steps taking forward. Once again, eculizumab, which was the prototype drug, given every 2 weeks. A new drug, ravulizumab, that appeared to last longer in the circulation, could be given less often, every 8 weeks, for example. Both of these agents affect the same part of the complement. It blocks the terminal phase of the membrane attack complex protein, C5 complex. And ravulizumab was shown to be non-inferior to eculizumab in patients who were naive or had previously received eculizumab. And ravulizumab has made a substantial improvement in the ability to care for people who need maintenance treatment for PNH, and it's given less often, given every 8 weeks. Still, you get tethered to an IV pole every 8 weeks. And as my patient said, please, how come you can't give me a pill? Why should I have to come in to get this drug so often? In summary, then, eculizumab and ravulizumab are FDA approved for the treatment of paroxysmal nocturnal hemoglobinuria. Thrombosis, usually venous, sometimes arterial, severe anemia, or symptoms associated with red cell destruction are indications for treatment. The drugs used to block complement inhibitors for the treatment of PNH, can increase risk for Neisseria infection. And everyone should be vaccinated against Neisseria meningitidis that causes meningitis. And vaccine therapy and prophylaxis against Neisseria are very important in people who are receiving these agents. Ravulizumab appears to be a better choice for people who require indefinite treatment with PNH. And there are new blockers of complement that are approved and soon to be approved, which could be given as pills or as injections under the skin. that can potentially be taken at home. As my patient, pseudonymed Miss Albright said, gosh, when can we have a pill? Danicoplan, here listed as phase 2, is a drug that has received breakthrough designation that blocks complement in its early phase of activation. Pegcetacoplan is a subcutaneous, like an insulin shot under the skin, that has completed approval. And so the next generation of complement inhibitors are on the horizon, as FDA approved treatment last year with pegcetacoplan. And danicoplan, which is the pill, has received breakthrough designation and probably will be used in combination with eculizumab or ravulizumab for the treatment of particularly troublesome phases of PNH. A cure for PNH still remains elusive, and if you had to eliminate the clone that causes paroxysmal nocturnal hemoglobinuria, allogeneic stem cell transplant from donors still remains a challenging but potentially curable option for paroxysmal nocturnal hemoglobinuria. And as Sir Dacey and others had shown, spontaneous remissions are part of the natural history of this disease, and for a very small number of patients that might be something that happens. So was Thomas Ham right that when we look through a knothole in the fence, what has the study of PNH shown us when we peer through the knothole? We have learned so much about the red cell membrane anchor protein, GPI, and its importance. We have learned so much about the functions of complement-mediated destruction of red blood cells, PNH as a prototype disorder for hemolysis. That the previous notion that if you had a clone, a single family of stem cells that started expanding, that it invariably leads to cancer or leukemia is false, and PNH has shown us that clonal expansion of cells does not always mean malignancy. New and rare disorders have been described: PIGM, PGIT mediated, extremely rare disorders. And as you can see from a brief mention, new therapeutics. So such a rare 1 in a million condition, PNH, has taught us so much about this disease. And we couldn't do this if people and physicians across the world did not partner together to do research in rare blood disorders. And so the last few slides tell us about registry. I showed you John Dacey and Luzato's paper from New England Journal of Medicine, 1995. They described 80 patients who taught them so much about this. Now, if the entire world joins together, then we could learn so much more by collecting these rare patient populations and sharing information and sharing research. So the Global Paroxysmal Nocturnal Hemoglobinuria Patient Registry is an important approach, or one such approach, to making a difference through research. It's a data collection study for patients around the world to share information about what will fill current and future gaps in research, and will allow us to really expand our knowledge that could be applied in so many other ways for so many other disorders perhaps as well. The key features are that it's really another much more comprehensive natural history study that, as I have shown you, can make a world of difference for this condition and others. The Aplastic Anemia MDS International Foundation may share de-identified data with individuals or institutions conducting research approved by steering committees. And I want to thank patients and their families who participate in clinical trials that have expanded our field of vision in what Thomas Ham at Boston City Hospital said was a knothole disease that has led to new treatment options for PNH. I am in deep debt and greatly admire hematologists worldwide who care so much to improve the lives of people with rare blood disorders. And Tom Poskett, who opened the door to hematology for me and my many teachers at Boston City Hospital who showed me the way. And I thank you very much for listening in to this talk. Thank you.
Thank you, Dr. Karnad. We have a few questions here from our participants. This one is a few questions together. Is there an easy way to explain how and why some red blood cells end up outside of the vascular system and in organs such as liver and kidneys? Do they go back and forth? And why are some complement inhibitors only able to help intravascular hemolysis and others extravascular hemolysis?
Well, thank you. That's a very good question. I'll take that in several parts. So yes, indeed, red cell destruction, as I've said, normally occurs extravascularly, never occurs within the blood circulation. It's designed to protect from problems when red cells fall apart within the circulation. So the so-called highly efficient disposal units in the spleen and the liver are macrophages, part of our body's immune system. So they are the cellular component of our immune system that helps take out things that are either effete and are dying or are inappropriate to be in the circulation. So they recognize signals and remove cells efficiently. So within the circulation, if you had to take out foreign invaders such as bacteria or infections, the immune system has evolved several different proteins, antibodies, or complement. And red cell destruction dominantly occurs in most conditions extravascularly because the system is so efficient, the cellular system is so efficient. The intravascular hemolysis occurs in inherited blood disorders, such as certain types of hemoglobinopathies, and in certain infections where parasites invade the red blood cells, such as falciparum malaria, where there's gross destruction of red blood cells within the circulation. So the byproducts of red cell destruction within the circulation then pass through the tubules of the kidney, and hemoglobin can be detected within the urine. So it's the end result of red blood cell destruction that shows up in the urine and in tubules of the kidney, and not the red blood cell itself. And then finally, the question about why it is that PNH is a disorder that selectively causes destruction within the circulation versus extravascularly. It has to do with the way complement-mediated destruction of red blood cells occurs partly. One phase of complement-mediated destruction is this membrane attack complex that pokes hole within the red cell membrane. Before that red cell, which is now flooded with things that are not supposed to be within the blood cell, reaches the cell in the spleen, it's already falling apart and gets destroyed. Which is not to say that complement-mediated lysis does not occur extravascularly. The proximal phase of complement activation indeed attaches a signal to a red blood cell that, hey, this red blood cell is abnormal, and this red cell is then taken out by the macrophage within the spleen. And this is why some patients with PNH who are currently receiving treatment, say with eculizumab or ravulizumab, which affects the terminal phase of complement activation, the red blood cell still accumulates the proximal C3 related complement proteins within the red cell surface, and then the spleen takes it out. So even though we are blocking the terminal phase of complement with ravulizumab or eculizumab, the extravascular hemolysis is due to the proximal phase of unchecked complement activation that still occurs due to CD55 being absent. And that's what happens. That's why you get both intravascular and extravascular hemolysis in some people.
Thank you. What is the risk of high bilirubin in extravascular hemolysis?
Right. So the most common conditions that cause hemolytic anemias are acquired disorders called autoimmune hemolytic anemias, such as warm IgG, autoimmune hemolytic anemia. This can occur for no reason at all. It can occur in people with lupus, with rheumatoid arthritis, with certain types of lymphomas. And the destruction of these red blood cells occurs in the spleen and liver because the red cells have an abnormal antibody attached to the red cell surface. And so the macrophages identify this as abnormal and they get taken out. So when that happens, destruction of red blood cells causes the processing of excess hemoglobin that's released from how these red cells get destroyed. And so one byproduct of hemoglobin destruction is bilirubin, and bilirubin is then cleared by the liver. So in people with hemolytic anemias that occur extravascularly, if they do not have liver disease, jaundice can occur, yellow discoloration of the skin, but it is rarely severe. In other words, it's rare to see bilirubin levels of 15, 16, 20, and so on. More often than not, bilirubin is modest, such as between 5 and 8 or so. And bilirubins at these levels are not toxic in any way. They just stain the skin and discolor the eyes, but do not, like in people who have liver failure, cause other problems. And so that's why bilirubin is at levels generally found in people with extravascular hemolysis really results in discoloration rather than true disease manifestation.
Thank you. Another question we have is, can you define what spontaneous remission would look like for a PNH patient?
Right. Well, certainly in the era before we had specific, let's say, complement-mediated inhibitors, in the New England Journal of Medicine paper in 1995, where a cohort of patients were simply being followed with periodic blood transfusions as the only option for treatment. About 20 of these 80 people over time, for no apparent reason, needed less and less transfusion, meaning their anemia spontaneously resolved and their hemoglobins kept staying up and up and up and finally into the normal range without requiring any blood support. And this happened in a minority of people followed long-term with PNH. In the modern era of people with PNH who require maintenance treatment with, let's say, ravulizumab or eculizumab, I anticipate that one way of this would be to have superb hemoglobins, completely normal hemoglobins, and then people asking the question of, well, what would happen if we stop treatment, and would the hemoglobin remain up? So for a lot of immune-mediated conditions, the only way to tell, and remember this is a minority phenomenon for which we have very little understanding. Spontaneous remissions, who gets spontaneous remissions, who don't. I'm not suggesting that people come off of therapy, but the only way we will know is if there is greater and greater time between treatments where no treatment is needed and hemoglobins stay up and no manifestations of the disease occurs.
Thank you. Our next question is, what is the current status of iptacopan being approved by the FDA?
You got me on that. Iptacopan, the pegylated peptide that is given by subcutaneous injections under the skin, is FDA approved now for specific cohorts of patients with PNH. There are a whole variety of clinical trials that are ongoing to decide where in the spectrum of PNH these disorders are I mean, these treatments are going to fit early versus late, pre-complement inhibitors, pre-eculizumab, pre-ravulizumab versus not, short-term treatments for specific cohorts of PNH, etc. So I am certain that, as is typical in the field of hematology and in oncology, where these are receiving rapid approval, we will begin to see more research come about as to who are the patients for which these are appropriate, and we will learn this fairly soon.
Thank you. What is the life expectancy for patients who do not have access to treatments with eculizumab or revulizumab, but only have blood transfusions or so-called therapeutic
Yeah,
apheresis? Yeah.
Very good question. Well, we have information pre-1995 from that paper that suggests that the median survival of supportive care options alone was 10 years in the New England Journal of Medicine paper that I quoted. More recent, this is information beyond 1995 up to 2006, that median survival is between 10 and 20 years. And indeed, Dr. Luzzatto mentions that a large section of the world's population still may not have access to eculizumab, ravulizumab, or any of the newer agents because of the expense involved. And since his work in Africa, he quotes Tanzania and countries like that where supportive care remains the only option for care. So between 10 years and 20 years. The main cause of serious trouble in patients beyond anemia is the complications of thrombosis.
Thank you. And we have another one that came in. I think you already answered this, or as well as you could. But when will we have an oral pill for PNH? I believe your pseudonym, Mrs. Albright, had asked that same question, right?
That's true. And, you know, the pill has been given breakthrough designation, meaning that in the early trials, it has been shown to be so effective in combination with ravulizumab or eculizumab, and it is being worked on to make certain decisions as to, you know, getting the safety data out. And at all of our hematology meetings, this will be updated, and I have no doubt in my mind that this will receive approval fairly soon, but for specific cohorts of people. I am certain that at some point there might be a pill available for upfront treatment, but this I cannot predict exactly when that would occur. There are smarter people than me who are hard at work, actually hands-on with danicloplan, for example, which has reached mature stages in the trials. So I have no doubt that we'll have it available soon.
Thank you. And you touched on this in the presentation, but can you discuss further how patients with the PNH clone, some may develop aplastic anemia or MDS, or how that happens with the PNH clone?
Right. So, autoimmunity or acquired antibodies that attack stem cells is at the root of what we call aplastic anemia. Unlike inherited mutation-related bone marrow failure syndromes, PNH never occurs in inherited disorders that cause bone marrow failure, but PNH clones can be identified in people who have aplastic anemia. Generally speaking, the PNH clone is at a very low level of detection. To just give you an idea of the patients with aplastic anemia that I have cared for in the last 17 years here in San Antonio, maybe 5 or 6 of them had 1% to 2% of their stem cells harboring a PNH clone, meaning that the flow cytometry showed absence of CD55 and CD59 in those clones. And those patients had no manifestations of paroxysmal nocturnal hemoglobinuria, no detectable hemolysis, no thrombosis, no symptoms other than the complications of severe aplastic anemia, as opposed to the occasional patient with aplastic anemia with classic bone marrow failure showing very low white blood cells, very low hemoglobin, very low platelets, and a bone marrow that looks like a ghost town, nothing there, completely empty bone marrow. But identifiable clones of PNH cells can be detected suddenly as high as 40% to 50%. These patients may need treatment for PNH during treatment for the background aplastic anemia, either immunotherapy for aplastic anemia side by side with eculizumab or ravulizumab, or stem cell transplantation for those patients who have donors for stem cells. So in addition to bone marrow transplantation, simultaneous brief use of eculizumab in particular has been demonstrated to be highly effective in suppressing the effects of the PNH clone as the aplastic anemia gets treated.
Thank you. And one final question: what are some concerns that PNH patients should be aware of? Should they need to go to an emergency room for perhaps an injury or some other illness? Are there particular precautions they should be aware of that they would need to inform other healthcare providers in an emergency setting?
Particularly, well, in order of frequency, then particularly important is that patients who are on complement inhibitor therapy, especially eculizumab or ravulizumab, people must know that they're at great risk for Neisseria infections. In fact, the younger the patient with PNH, some hematologists, in addition to vaccinating people to prevent Neisseria infections, will also use prophylactic antibiotics, the penicillin-related antibiotics, to prevent serious infections with Neisseria species. So emergency room doctors will need to be aware of complement inhibition such that they can use appropriate antibiotic therapy or look for infections with Neisseria species and take precautions to identify patients as immunosuppressed specifically for those infections. Secondly, the thrombosis that occurs in people with PNH can occur in locations that some emergency room staff may not be familiar with. The more common thrombosis is deep vein thrombosis of the legs, the usual condition called DVT, or pulmonary embolism called PE. This is the much more common venous thrombosis serious problem, but people who have PNH may present with unusual occasions, severe headache and confusion causing cerebral venous sinus thrombosis, or abrupt liver pain, liver swelling, and liver failure due to hepatic vein thrombosis. So unusual locations may highlight the need to look for PNH and treat PNH.
Thank you. And we received one more question. This will be the final question. Are low platelets a symptom of PNH?
Yes, thrombocytopenia can definitely be part of PNH, and some patients with PNH, instead of thrombosis, can have bleeding complications. It's much less often than the thrombosis that we see. And in some patients with PNH, the low platelets can be quite severe, especially those patients with PNH who have aplastic anemia, either aplastic anemia with severe PNH or PNH that's transforming to aplastic anemia. So thrombocytopenia or low platelets can be a feature of PNH.
Thank you, Dr. Karnad, for sharing your time and expertise with us today. We appreciate your taking the time to answer all of these questions and for your presentation. If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us at any time in 3 ways. You can send an email to help@aamds.org. You can call the AAMDSIF helpline at 800-747-2820, extension 2, or you can submit a question on our Facebook page. Please take a few minutes to complete the session survey. Your input is important to us and helps us plan future educational programming. Today's lunch program has 2 options. You can listen to patient stories of hope, or you can join chat discussions with other patients. To join the chat discussions, open the Community tab at the top of the home conference page and select Discussions. Next, select the group discussion you would like to join. These discussion groups are not facilitated and meant to be open conversations between patients and families. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The Aplastic Anemia and MDS International Foundation Medical Advisory Board and team are here to help you and your family as we have for the past 38 years. This concludes the session.